Avdesh will be speaking to us on safety and efficacy of suprachoroidal triamcino for pseudophakic CME.
Good morning, judges and dear colleagues. I am presenting a modified inexpensive needle safety and efficacy for suprachoroidal triamcinolone injections in macular edema. We all know that cystoid macular edema is one of the leading causes after cataract surgery, which is pseudophakic cystoid macular edema. And we frequently use topical drops in the management. However, in certain chronic cases, we may resort to intravitreal injections. Steroid implants are also used, but they are costly and they can cause glaucoma. Suprachoroidal injection of preservative-free triamcinolone is a recent addition to the armamentarium because now we have enough evidence that it is efficacious in various macular pathologies and macular edema, post-inflammation, and even diabetics and retinal vein occlusions. But the problem is that the preservative-free triamcinolone is commercially available at a reasonable cost, but the microneedle is not commonly available. And recent studies on outcome of depot steroid into suprachoroidal space have shown favorable results in terms of improved efficacy, lesser side effects, and longer duration of action. So to fill the gap of availability of a micro needle or a patented micro catheter, we modified a 26 gauge needle along with sleeve of a 22 gauge intravenous cannula for safe and cost effective delivery. So this is the needle, a routine 26 gauge needle, as you can see, and we have just put the sleeve of a 22 gauge intravenous catheter so that we have a graduated tapered end. And the injections are given 4 millimeters from limbus like any other intravitreal injection effortlessly. This is a short video on the procedure. So this is a 22 gauge catheter and the 26 gauge needle. First we have, with the help of a micro scissors, we cut this outer sheath of the catheter into two so it can be used in two separate injections, and then we pass this 26 gauge needle through this catheter. But we have to make sure that only this terminal 1 millimeter of the needle remains exposed. In most of these 26 gauge needles, the length of the beveled end would be around 900 to 1100 microns. Now, like for any routine intravitreal injection, we mark a point which is 4 millimeters from limbus. And then with this needle with triamcinolone, we hold the needle perpendicularly and apply gentle pressure so that you create a gentle dimple on the sclera. And then without any resistance, you just inject 0.1 cc of the drug, which will contain 1 milligram of triamcinolone. And then like for routine injection, you can put a drop of betadine and then patient can be left without a patch. So in these 20 eyes post pseudophakic CME, the mean age was 54.3 years. 60% of the patients were male. Mean duration of topical treatment was 13.8 weeks. They had already tried topical treatment. Mean visual acuity at baseline was 0.52, which improved significantly to 0.06, which was statistically significant. The central macular thickness reduced to almost half to 261 microns at the end of final follow-up at 6 months. And intraocular pressure at baseline and final follow-up was normal. And in this current series of 20 patients with non-resolving CME, the macular edema resolved and vision improved over a period of 12 months. No complications like endophthalmitis, retinal tear or lens damage were noted. There was no significant change in the intraocular pressure. These are some of the representative images from a patient who has received suprachoroidal triamcinolone. Here in the top panel, you can see the suprachoroidal space filled with the preservative-free triamcinolone. The second picture on top panel is the 3D reconstruction of the same OCT wherein you can see suprachoroidal space. And the third picture is a UBM with triamcino in the suprachoroidal space. And if you look at the bottom panel, we have baseline macular edema. You can see these large intraretinal cysts and see the dramatic response even on day one, wherein more than 50% of these cysts, they have collapsed, and you get a pristine retina at the end of 1 month. So this innovative needle is cost effective. There is no costly catheter or patented cannula which we have used. The material required is freely available and it is safe. And also this has wider applicability in macular edema of varied etiology, where cost of healthcare is important concern. And recently this technique is being adopted world over. This is one of the papers published in European Journal of Ophthalmology. And the technique per se was published in IGO, and this was published. Thank you.
Thank you. That was an interesting paper. Only thing is which I want you to tell us is that what was the frame of time in which you found the BVCA to be improving after the triamcino injection?
Ma'am, the vision started improving by third or fourth day, and by 1 month they had almost reached their final vision. But the most dramatic response was in the OCT, which was on day one itself. But by 1 week, the macular edema had reduced to almost half, and the final follow-up at 6 months, none of these patients had residual CME.
And how many cases did you work up?
These were 20 cases.
Out of 20 cases, there were any recalcitrant cases which didn't respond to treatment?
Ma'am, as part of inclusion in the study, we had not taken any other cases which predisposed to macular edema like diabetics or retinal vein occlusion and other systemic comorbidities or patient on any other drugs. They were simple, uncomplicated phacoemulsification CME cases.
Okay, and all of them you showed a response?
All of them
Was
responded.
there any need to repeat an injection?
No, not in any of these patients. We had 2 patients which were not part of the study. They were diabetics. So we repeated injection at 3 months when the edema started reappearing, ma'am.
So only the tip would be exposed. I think only the bevel where
Yes,
that is only exposed.
That
The
is
rest
only, yes, sir. That exposed bevel would be around 900 to 1100 micron,
Right.
depending on the make
So
of the
rest is all covered by that.
rest is all covered, and it doesn't allow that needle to enter further.
What is the reason for no increase in the intraocular pressure? Is it because many of these patients were on 13 weeks of topical treatment? So if the pressure would increase, they were weeded out first only?
The baseline pressure was 13.5 in these
Yeah.
patients as a group,
Yeah.
sir. But what I have noted that there could be immediate rise in the intraocular pressure. Immediate, I mean maybe first 24 hours or so. But at any other follow-up like 1 week or 1 month, the IOP was like baseline. There was no statistical difference.
None of these patients, the triamcino had migrated into the vitreous.
No,
It
none
was
of these.
only in suprachoroidal
Yes,
space.
we repeated OCT in each and every patient and did a fundus examination. We did not localize any triamcinolone in the vitreous cavity or on OCTs.
Why have you chosen this technique, and what is the comparative more why you have chosen this over the age-old trusted technique of posterior septenone?
Sir, posterior septenone is what, in my limited experience, I feel it's a blind procedure, sir. Sometimes the triamcinolone gets deposited in the subconjunctival space, so it does not actually reach the site of action. Here it is a technique wherein under direct visualization you are depositing the drug, and now there is enough evidence like peach tree, dogwood, they are all trials on triamcinolone in suprachoroidal space. So I felt it is much better than PST injection, but we need to have a head-to-head comparison. Maybe in times to come I'll do that. And other option we have is Ozurdex, and the cost actually for a poor patient is exorbitant, and this is inexpensive for a patient who is in need.
Because what I am doing, I am giving this posterior septenone with the butterfly needle. That's the same needle, and the cannula is going till the posterior part of the globe, and the chances of migration into the subconjunctival space is very, very less. So your technique, your needle, everything is same. Only thing is my triamcino is in the subtenon space, you're in the suprachoroidal space. In your case, you are going inside the eye. The chances of complication is there. In my technique, age-old trusted technique, the chances of the complication is very less. So you have to compare both the things.
Yes, sir. And in these techniques, sir, what these large trials they have found, they have done animal studies and now there is a lot of data. What they have found that raised intraocular pressure is very less with suprachoroidal injections because most of the drug that is routed posteriorly. So there are short follow-up studies by those trials. They have shown that more concentration of drug in this technique is found in the posterior segment as comparable to other techniques. That's the finding of their trials.